An i-OCT-guided fibrin glue rescue for a large iris cyst in an infant. There are no financial disclosures. A 6-year-old infant was brought by her parents with complaints of inability to open the right eye since birth. There was no systemic illness or any significant antenatal history. On examination, the child was highly photophobic and we could not examine the right eye properly because of her photophobia. On examination under anesthesia, we could see a large iris cyst which was obscuring the visual axis. The intraocular pressure was within normal limits. Since the pupil was involved, fundus was not visible, but ultrasound was grossly within normal limits. Her left eye was alright with no mass lesion. On this OCT, we can see a large iris cyst filling up almost the entire anterior chamber. The cyst measured up to 2.8 by 6.7 millimeters in size. Management options for iris cysts include cyst aspiration alone, associated with higher risk of recurrences. Other option is en bloc excision. Even though the entire cyst is excised in toto, it is associated with greater risk of collateral damage to the ocular structures. Laser treatment is a less invasive procedure but again associated with recurrences. Cyst aspiration with injection of a sclerosing agent is widely practiced as it has lesser risk of recurrences. Sclerosing agents include 5-fluorouracil, mitomycin C, trichloroacetic acid, or dehydrated ethanol. Even though they have lesser risk of recurrences, we must practice caution as intraocular use of these sclerosing agents could lead to local toxicity. Overall complications include corneal decompensation, intraocular pressure elevation, localized inflammation, and need for resurgery. We did a literature search to look for a non-toxic alternative. So on literature search, we came across this article published in the AJO in 2022 where a tissue glue was used for management of a large iris cyst with good results. But why fibrin glue? Fibrin glue mimics the final stage of the coagulation cascade and is biocompatible and biodegradable. Its safety and efficacy are proven in corneal perforations as well as in retinal breaks. In case of iris cyst, it facilitates adhesion between the cyst walls, thereby keeping the wall collapsed. It also enables complete cyst excision with minimal damage to the surrounding tissue and also prevents risk of recurrences. Our plan was a two-step approach. Step 1 was to tap and remove the cyst contents. Next, we fill the cyst cavity with fibrin glue and leave it inside the cavity. After 6 weeks, we plan to resect the cyst in toto. We performed iris cyst aspiration with intracyst fibrin glue injection under general anesthesia. So using the i-OCT, we could visualize the cyst properly, and using a 31 gauge needle, we aspirated the cyst contents and we could see the position of our needle using the i-OCT that we were in the right space. This was followed by injection of fibrin tissue glue inside the cyst wall. i-OCT again guided us in the same. Cytology evaluation of aspirated cyst fluid revealed no evidence of malignancy, but there were presence of few hemosiderin-laden macrophages. At 6 weeks follow-up, we could see that the iris cyst wall had collapsed on the OCT, and on eye examination we can see that the pupillary margins are now visible. Going by the second step as our plan, we performed iris cyst excision and peripheral iridectomy under GA. After forming the anterior chamber with cohesive viscoelastic we perform separation of the cyst wall from the endothelium using a spatula. After that, we excised the cyst wall and sent for histopathological examination. This was followed by aspiration of the remnant of the cyst using a vitrectomy cutter. After ensuring complete removal, we performed a peripheral iodectomy. The wound was then closed with the help of 10 nylon sutures. Histopathology of the cyst showed non-keratinized stratified squamous epithelium containing benign pigmented epithelial cells lined by flattened epithelial cells and goblet cells. At 1 year follow-up, we could see that the visual axis is clear and the cornea has also cleared out significantly well. The intraocular pressure continues to remain within normal limits, and this is the OCT which can show that there is some scarring of the corneal tissue but absence of any recurrences at 1 year follow-up. This child achieved good outcome and continues to remain recurrence-free at 1 year follow-up. Patching therapy has been advised to improve the vision in the right eye. To conclude, biologic fibrin glue may be considered as an alternative to toxic sclerosing agents in large iris cysts. The need for a secondary surgery for cyst excision is a limitation of this particular technique. More studies are needed to prove the efficacy and safety of fibrin glue in large iris cysts. Thank you for watching.